You know that feeling when something just feels stuck, like things aren't moving right in your gut.
Mm-hmm.
Well, that kind of unsettling feeling is actually a good starting point for our deep dive today into small bowel obstruction.
Yeah, it is. And we've got a really solid set of notes here to guide us. Our aim is to make this a really clear and useful session for anyone revising this topic.
Exactly. Think of it as your audio revision guide. We're going to cover, well, pretty much everything. The definition, the causes, risks, what's actually happening in the body.
How it's spotted, what else it might look like, who gets it, the signs, investigations, management.
Prognosis, and the potential complications, too. So let's jump right in. What is small bowel obstruction, basically?
Okay, so in simple terms, it's a blockage. Something stops the normal flow of food, fluid, gas through the small intestine.
Right.
And there are two main ways this happens. You've
Right.
got mechanical causes, like a physical barrier.
Something actually in the way.
Exactly. And then you have functional causes, where the problem is more about the bowel's movement or lack of it. The motility isn't working properly.
Okay, so physical versus functional. Got it.
And it's really crucial to stress this small bowel obstruction is serious. It's a medical emergency, needs quick diagnosis, quick action.
Right. Definitely not a wait-and-see situation.
Mhm.
Okay, so let's dig into those causes, the etiology. Mechanical first.
Yeah, let's do that. Probably the most common cause, especially in adults, is adhesions.
Scar tissue.
Exactly. Scar tissue from previous surgery, usually abdominal or pelvic surgery. These bands of scar tissue can sort of kink or squeeze the bowel shut.
Makes sense. So previous surgery is a big risk factor there.
Huge. Then you've got hernias. A loop of bowel pushes through a weak spot in the abdominal wall and can get trapped or strangulated.
Okay.
Tumors, too, both benign, non-cancerous ones and malignant cancerous ones. They can grow inside or outside the bowel and block it off.
Right. What else falls under mechanical?
Well, there's volvulus. That's where the bowel actually twists around on itself.
Ooh, like wringing out a towel?
Kind of, yeah.
Yeah.
Cuts off the blood supply as well as blocking the passage. Very serious. And then there's intussusception.
Intussusception.
Yeah, that's where one part of the bowel telescopes slides into the section next to it. Think of like an old-fashioned telescope closing up, often seen in kids.
Those are really helpful visuals. Okay, so those are the physical blockages.
Yeah.
What about the functional side, the motility problems?
The main one there is paralytic ileus. Ileus just means the bowel isn't contracting properly, it's sluggish, or has stopped moving altogether.
Then what causes that?
Often it's a reaction to recent abdominal surgery. The bowel just kind of goes on strike for a bit while it recovers.
Okay.
But it can also be triggered by infections like peritonitis or significant electrolyte imbalances, low potassium, for instance. Certain medications, like opioids, can also slow the bowel down.
So the plumbing's okay, but the pump isn't working.
That's a good way to put it, yeah. The machinery stalled. The notes also mention a few other things like gallstone ileus.
A gallstone causing a bowel obstruction. How?
Yeah, a really large gallstone can erode through the gallbladder wall into the duodenum and then travel down until it gets stuck, usually in the narrowest part of the small bowel, the terminal ileum.
Wow.
And fecal impaction, basically a large mass of hard stool causing a blockage, though that's more common in the large bowel.
Right. So are there specific causes we see more in kids versus adults?
Definitely. In children, especially newborns, you worry about congenital things, problems they're born with, like malformations or meconium ileus.
Meconium ileus. That links to cystic fibrosis, right?
Strongly linked, yes. Also, Hirschsprung's disease, intussusception, is much more common in kids. Volvulus can happen, and malrotations where the bowel didn't form in the right position.
Okay. A different set of worries there.
Yeah.
And in adults, anything specific apart from the adhesions and hernias?
Well, gallstone ileus is more common in older adults. Crohn's disease can cause strictures, narrowing, that lead to obstruction. Certain gynecological tumors can press on the bowel. And then there are bezoars.
Bezoars. What are they?
They're clumps of indigestible material. Could be medication bezoars, like undissolved tablets stuck together, or trichobezoars.
Hairballs.
Essentially, yeah.
Yeah.
Usually from people compulsively eating hair. And then a really serious one is body packing, people swallowing drug packets if one gets stuck or leaks.
That's a major emergency.
Okay.
So who's most at risk then? Let's run through the key risk factors.
Number one, as we said, is previous abdominal or pelvic surgery because of those adhesions. That's the big one.
Right. Adhesions seem key.
They really are. Also, just having adhesions, even without known surgery, is a risk. Then, hernias, especially untreated ones. inflammatory bowel disease like Crohn's.
Because of the inflammation and strictures?
Exactly. And cancer in the abdomen, obviously. A history of volvulus makes another episode more likely. Any kind of intestinal stricture or narrowing. Motility disorders. Older age is generally a risk factor, partly because older people are more likely to have had surgery or have other contributing conditions. And importantly, if you've had a small bowel obstruction before, you're at higher risk of having another one.
Right. It sounds like it can unfortunately become a recurring problem for some people. Any less common risks?
Yeah. Things like gallstone ileus, as we mentioned, maybe severe chronic constipation, complications from radiation therapy to the abdomen. But the ones we listed are the main players.
Got it. So let's move on to what's actually happening inside when there's a blockage, the pathophysiology.
Okay, so picture the blockage. Proximal to it, upstream fluid, gas, digestive contents, they all start backing up. They can't get past.
A dam effect.
Precisely. This buildup increases the pressure inside that segment of bowel. The bowel wall starts to stretch, gets distended.
And that stretching causes pain.
Yes, and as the pressure keeps rising, it starts to compress the blood vessels in the bowel wall. Blood flow gets compromised.
Ah, and that's the dangerous part.
That's the critical point. Reduced blood flow leads to ischemia, lack of oxygen to the tissue. If that's not relieved, the tissue starts to die. That's necrosis.
Necrosis. And then
the dead bowel wall can perforate, rupture, contents spill into the abdominal cavity, causing peritonitis, sepsis. It's a life-threatening spiral.
Wow. It happens fast.
It can, yeah. So maybe think of the 4 Bs. Blockage leads to buildup, leads to bowel distension, leads to blood flow compromise, potentially ending in really bad outcomes like perforation or necrosis.
Blockage, buildup, bowel distension, blood flow compromise. Bad outcomes.
Okay.
That's helpful. So someone comes in with symptoms. How do you know it is SBO and not something else? What are the differentials?
Good question, because lots of things cause abdominal pain and vomiting. First, you think about other bowel problems. Could it be a large bowel obstruction instead? Or a bad flare-up of IBD, like Crohn's or ulcerative colitis, diverticulitis, even severe constipation or IBS sometimes, though usually less acute?
Okay, other gut issues.
Then, infections or inflammation elsewhere in the abdomen. Gastroenteritis, a stomach bug, appendicitis, acute pancreatitis. They can all present quite dramatically.
Right.
Vascular problems, too, like mesenteric ischemia, lack of blood flow to the gut for other reasons, like a clot. That's another emergency. Or a perforation from something else, a peptic ulcer, diverticular disease, even a ruptured cancer.
Lots to consider. Anything specific for kids again?
Yeah, intussusception is high on the list of differentials for a child presenting with these kinds of symptoms. And very rarely things like abdominal TB.
And can things outside the abdomen mimic it?
Sometimes, yeah. Surprisingly, a heart attack and MI can present with upper abdominal pain. In women, things like ovarian torsion or even sometimes ovarian cancer can cause confusing symptoms. So you need a broad perspective initially.
Definitely need to keep an open mind.
Oh.
How common is SBO? What's the epidemiology like, say, in the UK?
It's hard to get exact prevalence numbers, but we know it's a really significant reason for emergency surgical admissions. It's common enough that anyone working in acute medicine or surgery will definitely see it.
And you mentioned older age as a risk factor. Is it mostly older adults?
It is more common in older adults, yeah. Largely because they're more likely to have had previous surgery leading to adhesions or have hernias or cancers, but really important to remember, it can happen at any age. Kids, young adults, middle-aged people, everyone.
Okay, so let's paint the picture clinically. What does someone with SBO typically look and feel like? What are the key symptoms?
Okay, the classic features. Abdominal pain is usually central, often crampy, colicky, comes in waves. But it can become constant, especially if strangulation is happening.
Right.
Abdominal distension. Their belly looks swollen, feels tight and bloated. Nausea and vomiting are very common.
You mentioned the vomit can give clues.
Yeah. Early on, or with a high obstruction, it might just be gastric contents, maybe bilious greenish yellow from bile. But with a lower obstruction, if it's been going on a while, the vomit can become feculent.
Feculent.
Feces, yeah. Smells foul, looks brownish. It's because bacteria have overgrown in the stagnant bowel contents above the blockage.
That sounds awful. What?
Absolute constipation, meaning inability to pass stool or flatus gas. That's a cardinal sign of a complete obstruction. Lots of appetite, too.
Okay. Any variations?
Sometimes with a partial obstruction, people might still pass some gas or even have diarrhea initially as the bowel tries to clear itself out below the blockage. And if peritonitis sets in.
That's the infection.
Yeah, infection or inflammation of the abdominal lining. Then you get marked tenderness, rigidity, The abdomen feels board-like. That's a major red flag.
Are there any specific sounds? I remember hearing about bowel sounds.
Yes. Early on in mechanical obstruction, the bowel is working hard to push past the blockage so you can get hyperactive, high-pitched, tinkling bowel sounds, like little bells.
Tinkling sounds. Okay.
But later on, or with a paralytic ileus, the bowel might become quiet, exhausted, so sounds could be diminished or completely absent.
So what does the physical exam focus on?
You're looking for signs of dehydration. First, dry mouth, sunken eyes, poor skin turgor, fast heart rate, low blood pressure maybe. Then the abdomen, look for distension, any surgical scars.
Scars hinting at adhesions.
Exactly. Measure the girth maybe. Feel for tenderness, rigidity, guarding. Percussion tapping the abdomen will often sound resonant or tympanitic, like a drum, because of all the trapped gas.
Drum-like. Okay.
Crucially, you must examine the hernial orifice's groin, umbilicus, to check for an incarcerated hernia. And listen with the stethoscope for those bowel sounds. Are they tinkling, sluggish, or absent? Putting it all together helps build the picture.
Okay, so you have a strong suspicion based on history and exam. How do you confirm it? Investigations.
Right. First line is often an abdominal x-ray, usually done supine and erect, or sometimes a lateral decubitus view.
What are you looking for on the x-ray?
You're looking for dilated loops of small bowel, typically central, wider than 2.5 or 3 centimeters, and air fluid levels on the upright film. Multiple air fluid levels looking like a staircase can be quite suggestive.
But x-rays aren't perfect.
No, definitely not. They can be normal, especially early on, or with a very high obstruction. Sensitivity is quoted as maybe 50–66%, so a normal x-ray doesn't rule it out if you're clinically suspicious.
So what's the next step, the more definitive test?
That would be a CT scan of the abdomen and pelvis, usually with intravenous contrast. CT is really the gold standard now.
Why is CT so much better?
It gives much more detail. It can pinpoint the location of the obstruction, often identify the cause. You might actually see the adhesion band or the hernia or a tumor, can show how severe the dilation is.
Okay.
And crucially, it can show signs of complications like thickening of the bowel wall, lack of contrast enhancement suggesting ischemia, free air indicating perforation, or free fluid. It really helps decide who needs surgery urgently. Think CT critical tool.
CT critical tool. Got
Yeah.
it. What about blood tests?
Essential. You need a full blood count looking for a raised white cell count suggesting inflammation or ischemia, urea and electrolytes looking for dehydration, raised urea, creatinine, and electrolyte disturbances from vomiting, like low potassium. Need to check renal function. A lactate level can be useful as it might rise with bowel ischemia. And always do a group and save or cross-match blood in case surgery is needed urgently.
And fluid balance charts.
Absolutely critical. These patients are often very dehydrated and need aggressive IV fluid resuscitation. Monitoring urine output is vital.
Any other scans or tests sometimes used?
Occasionally, if the diagnosis is still unclear, or maybe in specific situations like suspected Crohn's stricture, you might consider things like MRI, especially in pregnant patients, to avoid radiation. Ultrasound can sometimes be helpful, particularly in children for intussusception, or to look for dilated loops and free fluid, but it's very operator dependent. Sometimes a water-soluble contrast study, either swallowed or given as an enema, can help differentiate partial from complete obstruction or locate the transition point.
Okay, so we've got the diagnosis confirmed. How is it managed? What are the first steps?
Initial management is often summarized as drip and suck, or you can think NIM, NDM, nil by mouth, rest the bowel completely, 5E fluids, aggressive resuscitation to correct dehydration and electrolyte imbalances, and NG tube, nasogastric tube, passed down into the stomach to decompress the bowel by suctioning out fluid and gas.
So NBM, IV fluids, NG tube, that's the immediate plan.
Yes, supportive care initially. This alone can sometimes resolve obstructions caused by adhesions, especially if they're partial. This is conservative management.
Just waiting and supporting.
Essentially, yes, but with very close monitoring. If the patient improves, pain settles, they start passing flatus, the NG output decreases, you might avoid surgery. This is often tried for patients with known adhesions and no signs of strangulation.
But when is surgery definitely needed?
Surgery, usually a laparotomy, which is an open operation, is needed if there are signs of strangulation or peritonitis, like worsening pain, fever, tachycardia, high white count acidosis. We call these red flags or signs the patient is toxic. Okay. Also, if the diagnosis isn't certain, or if it's caused by an irreducible hernia, or if conservative management fails under a reasonable period, say 24 or 72 hours, depending on the situation, then surgery is indicated. Generally, if there's any doubt about bowel viability, you operate sooner rather than later.
Makes sense. Are there non-surgical options beyond just waiting?
For malignant bowel obstruction, particularly if palliative, endoscopic stenting can sometimes be used to open up the blockage. But for most acute mechanical obstructions, it's either conservative trial or surgery.
What about specific situations, like volvulus?
Sigmoid volvulus can often be decompressed initially with sigmoidoscopy or colonoscopy, but recurrence is high, so elective surgery is usually recommended later. Cacal volvulus almost always needs surgery straight away.
And pseudo-obstruction, the functional type.
That's managed differently. Focus is on treating underlying causes, like electrolyte problems. Medications like neostigmine can sometimes stimulate bowel movement, but need careful monitoring. Colonoscopy might be needed to decompress the colon if it's massively dilated.
Ogilvie syndrome. Okay. And malignant obstruction.
Often palliative intent. Steroids can reduce surrounding inflammation. Pain control is key. Stenting, as mentioned, can relieve symptoms. Sometimes palliative surgery or a bypass might be considered.
Right. So, assuming treatment works, what's the outlook? The prognosis?
Generally, if caught and treated early, the prognosis is quite good. Most people recover well.
But delays are bad.
Delays are really bad. The risk of ischemia, perforation, sepsis, and death goes up significantly if treatment is delayed.
Do we have figures on that?
Yeah, some studies suggest mortality might be around 3% with pump surgery, but jumps to maybe 14% or higher if surgery is delayed in cases needing it. Prognosis is obviously poorer if the cause is advanced cancer.
And recurrence. You mentioned volvulus.
Yeah, sigmoid volvulus has a high recurrence rate, maybe 50% within a couple of years if it's just decompressed endoscopically without surgery later. Adhesive obstructions can also recur. Certain factors predict poorer outcomes to older age, poor nutrition like low albumin, obstructions caused by non-GI cancer spreading.
Okay, so let's finish with the potential downsides if things go wrong or aren't treated fast enough. What are the main complications?
The big scary ones are bowel ischemia, necrosis, and perforation. We've touched on those. They lead directly to peritonitis and sepsis.
Which can be fatal.
Absolutely. The systemic effects are severe, too profound dehydration, electrolyte chaos, leading to hypovolemic shock, circulatory collapse, acute kidney injury.
Right.
If a large section of bowel has to be removed surgically because it's dead, patients can end up with short bowel syndrome. This causes long-term problems with absorbing nutrients, leading to malnutrition and dependence on IV feeding sometimes.
And the risk of future obstructions.
Yes, particularly with adhesive obstructions. Every abdominal surgery increases the risk of more adhesions, creating a potential cycle of obstruction.
You mentioned obstructing carcinomas.
Yeah, they are usually primary cancers of the small or large bowel that have grown to block the passage. And that acute colonic pseudo-obstruction, Ogilvie syndrome, if it perforates, carries a really high mortality, maybe up to 40%.
Wow. So it really hammers home that what might seem like just a blockage can quickly spiral into very serious, life-threatening problems.
Exactly. Timely recognition, investigation, and appropriate management, whether conservative or surgical, are absolutely key.
Okay, well, hopefully this deep dive has given you a really solid, high-yield overview of small bowel obstruction. We've covered a lot of ground, from the basics through to the complexities. Understanding all these pieces is so important for revision.
Definitely. And as you review, maybe try thinking about those subtle differences. How might volvulus present differently from an adhesion? How does the CT help narrow down the cause? Making those connections really helps cement the knowledge. Maybe try drawing out the pathophysiology pathway.
Great suggestion. And if you are revising for the MSRA and want more resources, practice questions, mock exams, definitely check out passthemsra.com.
And for free resources and questions, head over to freemsra.com.
Thanks so much for tuning in and engaging with this deep dive today.